How do I make sure that my patient is comfortable at the end of life without feeling like I'm hastening her death? Why do people at the end of life need more nursing care? What is the principle of double effect?
Join us as we discuss these questions and more on this episode of Medical Timeout. Welcome to Medical Timeout, a podcast where we discuss all things palliative care. I'm Rashmi Kadilkar.
And I'm Chinlin Ching. Today, we're talking about a really important topic, something that is both intuitive and controversial, if possible. Caring for someone at the end of life. This is important, Rashmi, because despite most people wanting to die at home, over 30% of deaths still occur in the hospitals. And the average terminal admission is about a week. So it's critical for our listeners to understand the importance of meticulous management of distressing symptoms at the end of life in the hospital.
That's right. And as a hospice medical director, I want to take the opportunity to reassure patients and their families that the care that patients should receive at the end of life should be just as intensive as when they were not on hospice. The care just looks different with a different focus. So Chinlin, what are some of the symptoms that we need to aggressively treat at end of life?
Well, Rashmi, it's actually all of the symptoms that we've talked about already in our previous episodes leading up to this particular episode. The obvious one and the one that people worry about the most is pain. Over 40% of dying patients in the hospital experience moderate to severe pain in the last 3 days of life. Dyspnea is the biggest fear of patients dying from CHF and COPD. The fear that they will suffocate to death is something we hear all the time. Intractable nausea and vomiting is unfortunately common in patients who are dying from malignant bowel obstructions as a consequence of metastatic cancer. And what we call terminal delirium or severe agitation and confusion at the end of life is also common. All of these symptoms can be very distressing to experience as well as to see. When we think about having a loved one die, seeing them comfortable is such an important part of the grieving process.
That's true. And as sad as we are that our loved ones are dying, that the final part of that journey is going to imprint on us. And that's going to shape the way that we think about death and dying for others in our lives, for ourselves, for the rest of our own lives. And so that's another reason why it's so important that we don't just assume that patients who are at end of the life in the hospital require less care and less attention. They actually require just as much, if not more care and more attention. So Chinlin, when we have patients who are at the end of life in our hospital, what is our usual nursing and rounding protocol?
Right. So patients should be rounded on by nursing at least every 2 hours, if not more. We write orders for comfort checks, Q2 hours, turns Q2 hours, oral care 2 hours. That is standard care. All PRNs should be written for at least Q1 hour PRN so that it's not that we want these patients to get medicines every hour, but if the nurse needs to give a medicine, they are not paging the covering provider. They're not waiting for a callback. They're not waiting for the clock to tick 3 hours, et cetera. And providers should be prepared to change medications to proportionately match the patient's needs. So there's really no holding back when we're caring for patients at the end of life. They deserve all of our attention because they're as they are dying, their symptoms can change very quickly. And so low nurse to patient ratios and frequent rounding, if you told anyone that, they say that sounds like ICU level of care, and it should be. Patients at the end of life need as much care as our critical care patients.
Right. And at the end of life, we're past the point where we're thinking about reversing the underlying causes. We're really concerned at this point with quick and effective symptom control. So how do we approach the aggressive management of symptoms like pain and nausea and dyspnea and terminal delirium?
So if you remember back to our previous episodes, we talked about layering medications and stepwise increases. This is sort of the same thing. We start with PRNs because we don't know what the patient needs. And again, we're using medications to match what the patient is looking like. So start with PRNs, but be prepared to schedule them if the nurses are using the PRNs all the time. It's the same medications that we mentioned in the previous podcast. And here's an important pearl. When writing for PRNs, PRNs, consider using objective signs of discomfort and pain, especially if the patient is delirious or unresponsive. Use objective pain scores. There's one that we call a pain AD or a respiratory rate. So a very uncomfortable respiratory rate for all of us is something over 18. And so if you say PRN for respiratory rate greater than 18, then it's a trigger that doesn't depend on a nurse walking in and subjectively thinking, does this person look short of breath or not? Mm-hmm. This removes any inconsistencies in subjective reports of discomfort, not just from the patients, but also providers, as I mentioned. Mm-hmm. Medications used should be checked frequently throughout the day, and checking in with the bedside nurse multiple times a day is part of our rounding routine at the end of life. Also, we tend not to write hold parameters for our medications for our end-of-life patients, and that's really, really important. We mentioned in a previous episode to write hold for sedation, but those hold parameters are no longer used for our end-of-life patients, right. Because what we need to remember is that patients look comfortable because they're on scheduled medicines that are maintaining their comfort. If we hold a medication because they're sleeping or they look comfortable, then we're going to start playing catch up and we're going to be behind. So if scheduled medications are not enough, then we start drips. So this is what I mean by stepwise layering. Mm-hmm. PRNs first, then schedule the medications. If scheduling them around the clock isn't enough, then you start a drip. Medications are added and layered. The key here is to adjust medications to the patient's need. So this feedback pathway loop that I'm talking about occurs multiple times a day. You round, you look at the medications that have been used, you make adjustments, you go back, you see what your changes have done. If you need to make more changes, then you do it then. So this feedback loop is two ways, happens all day long. And that's why we say that end-of-life patients need more attention instead of less. A colleague once said, and I agree with her, that an uncomfortable dying patient is a medical emergency, second only to a patient who is coding who wants to be resuscitated.
Yeah, that's such a good way to think about it, to really drive home the importance and the intensity that's needed at this time of life. I do want to go back and talk about one more symptom that we actually, I don't think, have discussed at all up to this point in our podcast. And that symptom is audible secretions at the end of life. It's what some people might call the death gurgle. And it's a natural part of the dying process. And it sounds awful. So we actually spend a lot of time counseling families and other caregivers at the bedside about what this means. I mean, the idea is that we all have, we're going to get a little bit gross here, we all have saliva and other fluids in our pharynx and in our mouth that we just swallow without thinking about it. When patients start to get closer to the end of life, they still have that buildup of fluids, but they either don't have the ability to, or it's not bothersome to them that they have these secretions. And so they don't swallow these secretions as readily as the rest of us do. And so these secretions build up in the oropharynx, and as air passes over them, it creates this gurgling sound that we hear outwardly and which makes us listening feel terrible. So the counseling that we often will provide is that this symptom of audible secretions bothers us more than it bothers the patient. It's not painful to the patient. And the reason we know that is that by looking at some of those other objective signs that you mentioned, what does the patient's face look like? What's their respiratory rate? We can tell that the patient isn't suffering as a result of these secretions. That being said, again, we talked about this idea that we want to make sure that those who are watching a loved one die aren't left with this really traumatic picture of what things look like. And so sometimes we will treat the oral secretions, partly to treat ourselves, but I think also just on the off chance that the patient's having some discomfort from them, we would much rather err on the side of comfort rather than not treating something. So some pearls about secretions. The best way to not have secretions is to prevent the secretions from happening in the first place. And one of the ways to do that is by limiting the amount of fluid going into the patient. And this is one of the reasons that stopping things like artificial nutrition and artificial hydration at the end of life is so important. Patients simply can't handle this extra food or this extra fluid that we're putting into them. And the way it manifests itself can be partly through these audible secretions that are so distressing. When the secretions do occur, despite our best efforts, the best way to treat is really to change position frequently, to make sure that people are upright, for example. And this is really another place where that very frequent nursing care comes in. We do sometimes use medications like hyoscyamine or glycopyrrolate, scopolamine, atropine, things like that to try to dry up the secretions, but they don't always work well. And sometimes drying up these secretions means that we're also drying up somebody's mouth, which can be uncomfortable in and of itself. And sometimes people talk about or ask for suctioning mechanisms. We really recommend, again, suctioning people at the end of life. Please don't do it. And especially, please don't deep suction patients. It doesn't help, and it can really be uncomfortable, and even painful. Now, we talked a little bit earlier about this layered approach to medication management and a proportionate escalation of medicines. And sometimes we talk about something called palliative sedation, which is a really important term. So what is palliative sedation?
So palliative sedation is necessary when the patient's symptoms while awake are so severe and they are suffering so much that we actually intentionally sedate them in order to relieve their suffering. It's an important concept and often misunderstood. There aren't many procedures that we own in palliative care, but palliative sedation is definitely one of them. We often hear from providers and nurses about the discomfort in the doses of medications that may be required to keep someone comfortable. We've seen doses of comfort medications get held because of fear of hastening someone's death. So this happens when providers don't understand the ethical principles behind how we treat patients at the end of life, which is why we want to take time right now to really unpack this. I'm going to use some words that make me cringe. People have asked me what the difference is between aggressive end-of-life symptom management and euthanasia or physician aid in dying. It makes me cringe because they are so different. And lumping them together implies that the person asking really doesn't understand any of them. Mm-hmm. But the crux of it all is intent and the double effect principle. Rashmi, can you help define the principle of double effect?
Sure. So the principle of double effect is used in medical ethics to validate using a treatment that's honestly intended to relieve suffering, even if untoward effects are possible. And so there are 4 core elements here. So number 1, the good effect has to be the one that we're intending. Number 2, the bad effect can be foreseen, but it is not in any way intended. Number 3, the bad effect can't be the way that we achieve the good effect. And number 4, the symptom has to be severe enough to warrant this risk calculation. So sometimes patients have symptoms and suffering that is just so severe that they're not responding to escalating doses and maybe even infusions of opioids, benzodiazepines, other medications. This is when the idea of proportionate palliative sedation comes into play.
And so the goal and intent is to relieve suffering, not to hasten or cause death. And that is key. And as we use proportionate dose increases based on the patient's symptoms, as you mentioned, meaning we start low and go slow and only increase if we need to. And for that reason, it's different from euthanasia and physician aid in dying. We wish that we had medications that did not have the side effects of possible sedation and respiratory depression. But I think our listeners also need to remember that more often than not, a patient's sedation is also likely due to their progression of disease and the fact that they are dying, and not from a singular medication like opioids or benzodiazepines. Blaming medications alone and withholding them not only harms the patient, but also our ability to adequately control their symptoms when we need to at the end of life.
Yeah, and I want to go back to this question of why is this important? Jinlin, why is this important for people to know?
Every medical provider will have to care for a patient at the end of life at some point. So they must remember that how a patient dies is just as important as how someone lived. And just as importantly, that person's family, as you mentioned before, Rashmi, lives on with the memories of this journey, of all of the things that happened around their loved one's death. And then it's imprinted on them, and it shapes how they make decisions about their own death and their children, and so on and so forth. Mm-hmm. So we must make sure that misperceptions of a horrible, lonely death and the fears of abandonment when there are no more disease-directed therapies are dispelled.
And the way that we do that is by continuing to focus on intensive symptom management and intensive nursing care, even at the end of life. So on that note, let's summarize a little bit about what we talked about today. So the most common symptoms at the end of life are ones that we've already talked about: pain, dyspnea, intractable nausea and vomiting, and delirium. It's really important for nurses and for hospital medical providers to know how to treat patients at the end of life, because despite the fact that the majority of patients want to die at home, over 30% of deaths still occur in the hospital. Symptoms can become severe and intractable at the end of life, and they can change really quickly. So it's imperative to round frequently and intensify patient care at the end of life. And when people look comfortable, don't hold their medications or decrease their medications. Remember, the reason that people look comfortable is that their comfort is being maintained by the medications that they're receiving.
Right. And the principle of double effect and intent are what guides our ethical care of those patients at the end of life. And remember that how a patient dies is just as important as how that person lived. We must do everything we can to ensure that the journey is devoid of suffering and that dignity and comfort are prioritized above all else.
Yeah, and lastly, if you as a medical provider are uncomfortable with the doses of medications that are needed or with any other aspects of end-of-life care, then please don't hesitate to call and ask for help. Otherwise, it's not just the dying patient who suffers, it's also that patient's family and friends and loved ones who may have to witness what's a potentially bad and horrible death.
Right. Transitioning now, Rashmi, to the part of our podcast when we shift our focus onto DEI issues and disparities. Unfortunately, as usual, there are many studies out there that have shown that there are tremendous disparities in how people die in America, not just racially or ethnically, but also socioeconomically. Mm-hmm. So there's a lot of disparity in end-of-life care access to people in America. There's disparities in symptom control, as we mentioned before, accessing medications that are needed for appropriate symptom management based on race and ethnicity, because the medications we use and we lean on in this phase of life and death are opioids and benzodiazepines. The same racial disparities occur here as well. Geographically, where you die can also be disparate. So studies show that people in rural areas and regions hit hard by the opioid epidemic often suffer from uncontrolled pain and dyspnea at the end of life because providers are not comfortable prescribing these medications. And then also accessing these medications and also accessing providers who are comfortable using these medications can be difficult in rural parts of our country as well.
So I think what I'm hearing you say is that more than ever, we need to start with the education of healthcare providers, which is why we're doing exactly what we're doing here.
Yeah, absolutely. And Rashmi, onto our pet peeves. What drives you crazy about the way patients are treated at the end of life? For me, as I've mentioned before, it's the way we talk about comfort care. We've talked about the all or nothing speech that we hear. It just needs to stop. We cannot talk to our patients about transitioning to end of life as if it's a failure or as if it's devoid of care. And we need to understand, and then we need to educate our patients and their families that care at the end of life should be as intensive as the ICU. It's just as critical. What do you think?
I agree 100%. There's this terminology out there that we hear all the time where people talk about, stopping care or withdrawing care, or there's nothing more we can do. There's a lot more we can do, and it's pretty intensive. And so we definitely need to work on getting that message out there, that transitioning to comfort care doesn't mean stopping care. It means changing the focus of the care. And we talk about this being akin to ICU level care. And so a hospice team or a palliative care team, in this sense, we are the end of life intensive care unit team. And so, given our expertise and our training and our dedication to providing this kind of care day in and day out, I admit sometimes it's a little distressing when, very well-meaning friends, family members, hospital colleagues, pharmacists sometimes share their concerns with the patient and the family instead of sharing their concerns with the treating clinician. So for example, a family goes to the pharmacy to pick up a medication intended to relieve suffering at the end of life, and the pharmacist balks at the doses of opioids that are prescribed, which is appropriate within their scope of practice to do. I just wish that they would pick up the phone and call whoever prescribed it rather than telling the patient and family, wow, this is a really high dose. Are you sure he should be taking it? Because chances are the prescribing clinician made a very thoughtful decision to prescribe as they did. Having these discussions with patients and families without involving the prescriber or the care team contributes to anxiety and distrust about what a palliative care team or what a hospice team is doing. So I would implore anybody out there, no matter what your role in the care of a dying patient is, if there's something that's making you uncomfortable about what a palliative care team is suggesting or what a hospice team is suggesting, please talk to that team about it. We are happy to discuss our reasoning with you, with the patient, with the family. And I can't tell you how many times just simply having that discussion with the family about here's why we prescribe this medication, here's why we're using the doses that we're using. I can't tell you how many times that has really shifted the family's perspective and allowed the family and the team to really alleviate a patient's suffering at the end of life. Remember, this is not just for the patient, it's for the family too, and for everybody. We only have one chance to get this right.
Absolutely. So for many reasons, we'd love to hear from you. Please send us questions, comments, or topic suggestions by emailing medical_timeout@urmc.rochester.edu.
This podcast is supported by a grant from the System Transformation Fund through the Safety Net and Program Support Office with UR Medicine. Thank you to Dr. Kevin McCormick and to Nancy Scott for spearheading the grant and for their commitment to palliative care education.
Thank you to Levi Ganji for the music that we use, and a huge thanks to Nick Davis and Genesee Valley Media for editing, recording, and producing this podcast.
And thank you to you for taking this medical time out with us. We hope you'll join us next time when we will begin a series with some expert guests. Have a great couple of weeks.